Hi, everybody. We are s- going to talk about neurological disorders this morning. I do encourage you to, if you need to go back and review your neurological assessment. It is so important when you are working with mental health patients and some of the disorders we're going to be talking about this semester. So I do encourage you to go back and do a little review of assessment. All right. We're going to talk briefly about a number of topics. Some of the neurocognitive degenerative disorders we are actually discussing in your other course, but this is just a quick overview of some things that you may encounter in the psychiatric mental health setting. I will start with headaches. When you're talking about headache, there's really four different categories. There is what we call a contraction headache or a tension headache. There's vascular headaches, which include both migraines and cluster headaches, a combination, and then there's inflammatory headaches. And we'll kind of talk about each of these individually, just briefly. One thing that helps me to keep up with things like this is to kind of chart it out, just to keep it in my mind. That may be one way you can kind of keep these straight. Um, Tension headache is probably the most common kind. These generally occur bilaterally. They're usually, they feel tight, they feel like pressing. Nothing really cause them or trigger them necessarily. Um, you typically don't have any nausea, vomiting, or light sensitivity associated with them. We treat these generally with just your general acetaminophen, NSAIDs, or a combination. Sometimes with some caffeine can help as well. And that's a very common headache that you will see. Migraines can be, and there's a whole world to talk about migraines, but we're just going to touch on it today. There's a lot of different types of migraines and different presentations of migraines. Migraines last anywhere from 4 hours to 3 days. They may have an aura associated with them. Um, some kind of prodrome before they come on. They are pulsating and they can be quite severe. They typically occur on one side instead of bilaterally and are made worse by light, noise, any activity. So they're often associated with nausea and vomiting. And again, a lot of times people have kind of a prodrome prior to getting these. And sometimes people are able to identify triggers that cause their migraines, something they eat, age, stress, different things like that. Abortive therapy is what you use once the migraine has come on. These are a host of different things we use. Sometimes people just take your simple Tylenol, ibuprofen, but a lot of people will take something like a triptan. Um, so some of these many people also need to take an antiemetic with it. These are several of the medications taken, migranol, again, triptans, ergot derivatives. Sometimes if people have severe ones, they will go to the ER and will actually get a Toradol and or a dexamethasone injection. We also have some preventative therapy, which are things that people take on a regular basis. Lifestyle changes are number one. You need to look at what are their triggers? Is it caffeine? What is it? They need to work on their lifestyle and getting enough sleep. But then some of the preventative therapies that are used are beta blockers, tricyclic antidepressants on a daily basis, such as amitriptyline, and some of your anticonvulsants, such as topiramate, gabapentin, or valproate, can also be used as preventative therapy for migraines. Cluster headaches. Cluster headaches usually occur at night. They last anywhere from 15 minutes to 3 hours. They are unilateral, often around the eye or the temporal area, and they come on with these sudden, quick bouts of intense pain. They can often be associated with some autonomic symptoms such as tearing. People can get really restless and agitated because the pain is quite severe. It is more common in males, and there is a genetic component to this. Um, you can be diagnosed if you had at least 5 attacks of this a year. and it's accompanied by either some autonomic symptoms or some restlessness or agitation. The treatment is oxygen, and if it's severe and they go in, or Imitrex. Um, Again, sometimes they don't last very long, but sometimes they do, and it will be burst of severe pain, followed by nothing and then severe pain. Verapamil is one of the medications, calcium channel blocker, that's given as a preventative for cluster headaches. Traction or inflammatory headaches can be a medical emergency. They're usually described as the worst headache I've ever had in my life. This can be something like a subarachnoid hemorrhage, or something of that nature. Could be something like temporal arteritis in older people, or another type of hematoma. So if somebody comes in with severe headaches, it is definitely they need a CT, a non-contrast CT, immediately to determine, is this something severe? And diagnosis, typically we don't do any tests for headaches. We just get a really good history to determine what kind of headache this actually is. Again, if this is a severe headache, especially in an older adult, but even in a younger one, worst headache I've ever had, then a CT might be warranted. We often can then also add lab work to rule out any systemic illness associated with this headache. And let's see, another thing that causes headaches is temporal arteritis. Temporal arteritis is it's a headache, usually occurs in the temporal area. If you palpate it, you will feel often a nodule. It will be pulsating and very tender. It's associated with polymyalgia rheumatica, and can be associated with visual disturbance and other systemic symptoms. To diagnose it, they will always have an ESR, elevated ESR. To confirm a diagnosis, you have to get a temporal artery biopsy. But if you have somebody with these symptoms and an elevated ESR, you're going to treat them anyway with high-dose corticosteroids. Untreated temporal arteritis can lead to loss of vision, so it's really important to catch this. Sorry about that pause. Moving on to seizure disorders. We'll talk a little bit about them. We know that seizures are caused from an uncontrolled electrical activity in the neurons. We want to know, when you're looking for differential diagnosis for seizures, it's important that you're looking for different etiologies that may cause these seizures. And some of these are things like a CVA, having some kind of central nervous system infection. Somebody can be hypoxic and have a seizure. You can have psychogenic seizures, which look just like a seizure, act a lot like a seizure, but they have no physiological basis in them. A seizure might not be a seizure at all. It might be a movement disorder. Fever can cause seizures. Head injuries can cause seizures. Some types of metabolic and toxic conditions, some metabolic derangements, toxicity can also cause seizures. Anything lesion in the brain is also suspect. We can have seizures from drug and alcohol withdrawal as well. So seizures are something you will not uncommonly see in the psych mental health setting, particularly in inpatient units or in the ER. Also allergies. When someone has epilepsy, that's when they have chronic seizures with an unknown etiology. They're idiopathic. We don't know why they have them usually. We'll go over the several different types of seizures. The generalized seizures are ones that involve the whole body, and there's different types of those. It can be a tonic seizure, where you see just increased muscle tone. It can be clonic, which is rhythmic jerking movements. Myoclonic or shock-like contractions of certain muscle groups. It can also be a seizure that's atonic, and often you'll see tonic, atonic happening back and forth as the seizure. But atonic is a sudden loss of the muscle tone. You can see an absent seizure. We often see this with in children. They'll just stare off into space. They will have some impaired consciousness. That can happen. And then, of course, you know what we are familiar with are tonic-clonic or grand mal seizures. We also can have focal seizures. These can occur, or partial seizures. They have two names. These can occur with a loss of consciousness or without a loss of consciousness. Those without loss of consciousness rarely last very long. Those motor symptoms are often in a single group. They don't have a loss of consciousness, but however, it can spread to other parts of the body and result in paresthesia, hallucinations, flashing lights, things like that. So they can have some visual and they may make vocalizations as well. And you can also have a partial seizure with a loss of consciousness as well. How do seizures progress? A prodrome is when somebody's had a seizure, you have to ask a lot of questions. One thing you want to know is what were they doing prior to the seizure? A prodrome might be something like strong emotions, intense exercise. Were they at a place with flashing lights, like a big concert or something, loud music? Are they running a fever? Were they stressed? Were they sleep deprived? And also, are they on a menstrual cycle? So that's what are you doing prior to the seizure? That's different from an aura. An aura is something the patient experiences themselves that if they've had seizures, sometimes they recognize it. Maybe it's a smell, some visual thing happening like spots or flashes or some auditory thing, but that is a sensation that occurs just prior to the seizure beginning. The ictal phase of the seizure is when the movements are occurring or lack of movements, whichever kind it may be. When you actually see this in person, you want to note things like how long each phase lasts, what is their pupil reaction, whatever area of the body is involved. Are they incontinent? Were they conscious or unconscious? Do they have any tongue biting or lip smacking? Now, the post-ictal phase occurs after the seizure that has passed, but often people are really tired. They may sleep for extended periods of time. They're very lethargic. They can feel just exhausted. They may be sore if the seizure lasted very long, just feel really down. You always want to check for any weakness or paralysis or their ability to speak if they're conscious. Sometimes they seem a little out of it. Because a CVA can cause a seizure, you always want to rule that out as your etiology. So a good neural exam is imperative. When you're looking at their, you want to get a detailed history. Was there any illness, trauma, neurological deficit? Were they lightheaded prior to this? An accurate description is really important deciding if this was in fact a seizure. Was it a seizure, or were they having vertigo and passed out, or were they dizzy from hypoglycemia or hypotension and passed out? You want to ask them if there was an aura. What was the onset, the type of movements? Did it start in one part and spread to others? How long did it last? Were they awake or not awake? Were they incontinent or not? And was there any behavioral or neurological changes afterwards? It's really important if there's a witness there, because somebody who's actually experiencing the seizure themselves, they may not be able to give you a very good description of what occurred. I had a patient at the free clinic, and she came in and she kept talking about her mother coming home and finding a few times and just finding her kind of passed out on the floor. She said, "I'm passing out, I'm in the floor." I said, well, and so I've started asking questions, and one of them was, "Are you incontinent when you pass out?" The answer was yes. How are you afterwards? So I was pretty sure we were dealing with a seizure event, not a syncopal episode. And I walked out of the room to take a phone call and walked back in, and she was having a grand mal seizure. So my diagnosis was confirmed very quickly. But sometimes if it's unwitnessed, they don't know what happened. So anytime there is a seizure, you want to do a good physical exam afterwards. You want to check for any injuries that could occur that could have bitten the inside of their mouth or their tongue. Do a good cardiovascular assessment. Again, was this a syncopal episode? Was this a seizure? Was it arrhythmia? There's a lot of things to check. Make sure that you do postural vital signs to determine if there was perhaps an orthostatic hypotension that really wasn't a seizure. Complete neuro exam. Is there any lateralized weakness? Is there any memory problems, changes in reflections? All of those things could indicate a brain lesion. And then, again, your physical exam may be completely negative. Pharmacological management, you can, the goal is to control with one drug. These are some of the common drugs that are used for seizure. There are some people that do require more than one drug, but the goal is always, can we control these seizures with one drug? Anti-seizure medications do have some side effects. They're typically titrated up very slowly. In the psych mental health world, as you can see, we use some of these medications for mania and other things. You'll notice they're valproic acid. You'll see some clonopine, carbamazepine, and there's some others as well that are seizure medications, but we also use for bipolar, for behaviors, mood disorders as well. So, things that the patient needs to know, and I tell you this just because sometimes it's really good for you to reinforce. It's not uncommon to have a patient with a mental health disorder with a co-occurring seizure disorder. You will find this to be not uncommon at all. So sometimes it's good if they have a new diagnosed seizure disorder, to reiterate the things they need to do. Keep a record of their seizures, how often, if they're on something like Depakote, do they need to have labs drawn? What are the signs of toxicity of the medications they're on? The importance of minimizing alcohol and of being very adherent to their medications. Safety issues are really important. One of the biggest things is, things like swimming. They should never swim alone. Cooking, driving. In Georgia, if you've had a seizure, you cannot drive for 6 months. This causes a lot of changes in people's lifestyle, and that's really difficult, but important. Somebody with a ongoing seizure disorder, a service dog can be really helpful because they can let the person know before the seizure occurs. They will recognize the seizure coming on so they can get safe. There are some surgical interventions for seizures now, where they'll remove the focal area responsible for that seizure activity. It's a microsurgical technique. And there's also implantable generators to control focal seizures. So there's some new things coming around the block, because as you know, a seizure disorder that is not controlled can really alter a person's life and decrease their functionality. Trigeminal neuralgia is another neurological symptom that you may see. Trigeminal neuralgia occurs more in women. It is those three nerves of the trigeminal nerve. And if you remember, the three sensory nerves kind of have a branch that kind of comes down to your eye, comes down here, comes down here. This is when you have just a severe electrical pain. It can be disabling. It can last for just a second or for a couple of minutes. Some of them will continue to have like this ongoing, weird, deep neuro pain between the stabbing pain. It's more common in women. People who have it can have triggers like chewing or shaving, but some people just have it. They'll often get autonomic symptoms with it, where they'll get the eye tearing, the conjunctiva will get injected, they'll get some rhinorrhea. There's really no diagnostic test needed. It's pretty obvious if that's what it is. Here it says first line is carbamazepine or oxcarbazepine. I don't really like either one of those. You can use other seizure medicines to control it, but also what I see used even more are tricyclic antidepressants as controllers. I've also seen when somebody's having a bout of this with unknown etiology, it can be caused from a dental thing, but not always. I have seen people respond to a short 3-day run of dexamethasone, just knock that inflammation down. So, but it is, people who have this very badly, it can be associated with high rates of suicide. It is, if it is uncontrolled, it is crippling and renders people completely not functional when they're having an attack. Bell's palsy, this is when someone has an acute flaccid paralysis on one side of the face. They are all other central nervous system symptoms are negative. This is cranial nerve 7 that's affected. They usually have an inability often to close the eye or wrinkle the forehead, and they will also have some excessive tearing as well. It usually resolves, but some people have some ongoing symptoms. Eye care is really important. You also want to make sure, first line treatment is steroids. So let's talk a little bit about MS. I bring this up because you will have a lot of patients who have things like MS, and they also have they'll have some depression and other mental health disorders in conjunction with it. MS is an autoimmune disorder. The cause is unknown. We know that it's characterized by inflammation and devitalization. It's more common in women, and typically the onset of age is 15 to 45 or so. More common in Caucasian women, and it's second only to trauma in causing disability among young adults. It's also more common in cooler climates. They think that it's possibly a viral infection that triggers this. There's several different ways these symptoms can progress. Symptoms vary with MS depending upon the location of the lesions in their brain. Some have such mild symptoms that they don't even report them, such as fatigue and maybe a little paresthesia with a little weakness. They can have lack of coordination. Some people do have pain. They can have loss of balance. Those are the ones that gets reported usually. The typical presentation of MS is the relapsing and remitting symptoms. If you look up there on the chart, these symptoms they'll have like a flare up. And typically, the first few times they have a flare up, they will return to baseline. At some point, they may then have some disability after the flare up and not return to baseline, and eventually have increasing amounts of disability. That's the most common way that this presents. Less common progression types, there's a primary progressive kind, in which the patient will just gradually get worse and worse over time. There's also the secondary progressive, where they'll start off looking like they have a relapsing remitting type, but then they will move more into a primary progressive type pattern. And there's a progressive relapsing where they have flare-ups, but then they'll get better, but they never return to their baseline, and they just still are getting worse the whole time. Clinical manifestations, again, they vary depending upon where the lesion is, but these are some of your common clinical manifestations that can occur. Bladder symptoms are a telltale sign, paresthesias, a lot of different ones. And if you think about this, sometimes people have fatigue and they can't pay attention, and they just feel weak. That's why it's really important that you can do a good neurological assessment, because sometimes people are seeing you and they haven't even been diagnosed with something like this yet. You can see some visual changes like nystagmus, some diplopia, weakness, loss of sensation. So always ask a lot of questions. You might be surprised what you'll find. Good prognostic indicators for MS, in other words, this is hopefully not going to be too bad, is if they begin having symptoms prior to the age of 35. They are having minimal disability after 5 years, and they're having rapid remission of their initial symptoms. If their exacerbations are not very long, and they've had some long remissions, those are all good prognostic indicators. Poor prognostic indicators are for those who get MS later in life, if they have the more progressive courses, if they have motor symptoms or they have a lot of symptoms from the very beginning and they're experiencing vertigo. These are poor prognostic indicators. There's really no definitive test, but you do need to rule out other etiologies. We need to check a CBC. We need to look at a B12. Do they have Lyme disease? What's their SED rate? What's their RPR? We're looking for syphilis. Their ANA, looking for lupus. Their TSH. A good history, a good review of their symptoms. Sometimes people, you won't be doing this, but sometimes people will get, depending on their symptoms, will get a CSF cultures, and these will show some bands of immunoglobulin G, which that indicates an immune response. The brain will show damage over time caused from MS. They will begin to have these lesions that you'll see on an MRI. There's really not any big management. There is some management, but we want to manage their chronic symptoms and treat their acute exacerbations. And how do we do that? Exacerbations are typically treated with corticosteroids, but we do have disease-modifying agents that can be started early on to prevent progression of this disease. Of course, these modifying agents cause significant immunosuppressant, so they have to be aware of that. Stress is a really big trigger for exacerbations of MS. So it's one way you as a mental health provider can help with them managing their stress, their anxiety, to help decrease their number of exacerbations. These are some other common symptoms that people with MS experience and some of the medications that you may see given. Again, spasticity, baclofen, but you will sometimes see, if the spasticity is significant, benzodiazepines given for that. Fatigue is a big complaint. There's nothing FDA approved, but you will see things like Provigil and perhaps some other stimulants given just to improve their quality of life. If they're very ataxic, you may see propranolol given, benzos or GABA. They often have bladder dysfunctions and will be put on anticholinergics. But remember that anticholinergics do increase post-void residual. So they may have some then issues with urinary tract infections. If they have pain management is important as well. And some people actually do also have bowel dysfunction and need to be on a bowel program, especially later in the course of the disease. Another autoimmune disease that you will see that affects the nervous system is myasthenia gravis. In this, you have some antibodies that actually impair the transmission of impulses by affecting, excuse me. Of course, these affect the acetylcholine. What you will see with myasthenia gravis is just a generalized weakness. You may see ptosis on one side and diplopia, some weakness of the facial muscles. They might have some issues with their speech and some issues with swallowing. Whereas you really won't see that with something like Bell's palsy. Um, so it's a little bit different. There's some tests to see if this is in fact myasthenia gravis. One of those is the 10-line test, in which an acetylcholinesterase inhibitor is administered, thus increasing the availability of acetylcholine, and the symptoms will improve significantly for about 5 minutes once you've done this. It's a pretty easy test to do. There's some other tests. I don't really expect you to know those. You can get an EMG. There's also an ICE test. This is somebody with before myasthenia gravis and then with it, so you can see the difference there. The clinical course of this disease, in the active phase, they have a lot of more fluctuations and flares. They can get myasthenia crisis. In the stable phase, the symptoms become stable but persistent, and some do go into remission. There are some medications that can be given for this. Of course, one of the big ones is the anticholinesterase, which will inhibit the breakdown of acetylcholine. There's some immune modulating medications. They can get steroids. Many with myasthenia have thymus hyperplasia or a mass on their thymus, which is thought to be the source of this antibody production. So sometimes there's a removal of the thymus gland is indicated. Sometimes plasmapheresis is done to temporarily reduce the antibodies, and that's really only used in crisis. There are some complications. There's myasthenia crisis, where they suddenly get severe weakness of the respiratory and oropharyngeal muscles. They will get really weak. They may have respiratory distress, but this can come on from, there's a number of things, a change in your medications. Vigorous activity, heat, pregnancy, infection can cause this. It's treated with glucocorticoids, immunoglobulin, the plasma exchange, and some people require actually critical care support for this. One thing important to teach people, because those oropharyngeal muscles, their muscles of swallowing, can be affected, is to take small bites if they bend their head forward when swallowing, to sit upright while they're eating. They often will need to use artificial tears. If they're having trouble with their eye closing, they may need to take that eye shut for a while. Guillain-Barré is another thought to be autoimmune. This is demyelinization of the peripheral, and also the cranial nerves are involved. And it occurs in an ascending pattern, usually starting in the hands, the feet, the legs, the arms, and moving upwards. Because the cranial nerves are involved, it can lead to other complications such as blindness, dysphagia, problems, vagal nerve involvement, which can lead to cardiac instability, where you'll see things like tachycardia, bradycardia, hypotension, hypertension. They also will be hyporeflexive and have paresthesia and an inability to initiate voluntary movement. It's often thought to be precipitated by a viral infection. It is treated with immunoglobulin and sometimes plasmapheresis along with supportive care. If this ascends enough to involve the respiratory muscles of the diaphragm, then critical care will be needed. And often they will need rehab at discharge. All right, lastly, we're going to talk about, well, not lastly, next to last, we're going to talk about a couple of the degenerative disorders that we really didn't talk about in class. One of those is ALS, or Lou Gehrig's disease. In ALS, we've talked about some of these diseases cause demyelinizations. Some of them are due to a problem with a neurotransmitter. ALS is due to a problem with the nerves itself. They lose loss of the motor neurons in the spinal cord and the lower brainstem. We don't know why people get it. Symptoms are symmetrical, presenting on both sides. They may come in with just a gait disturbance and some weakness. Usually starts in the lower extremities and moves up to the trunk. They do have their cranial nerves are also affected. So you may see issues with speech, swallowing, coughing, blowing nose, or breathing eventually. The manifestations are very variable. They will have the weakness, cramping. Sometimes they'll have the fasciculations. You'll see twitching. Fatigue is always present. Eventually, you will see spasticity, and eventually you will begin to see cognitive decline. Bowel and bladder are usually spared except at the very end. Unfortunately, there's no cure. Treatment is symptomatic, and the average survival is pretty low, 3 to 5 years. So a lot of discussions on end of life care, family support is very important at this time. Just like with Alzheimer's or any degenerative diseases, questions concerning end of life care and what the patient wants should happen early on in the disease process while they can make the decisions. Now, lastly, on neurovascular disorders, a stroke can present in a lot of different ways. So that's why it's really important to do a good neuro exam. You don't want to miss it. There's several different kinds of strokes. There's hemorrhagic, there's ischemic, and there's transient ischemic attacks. The risk factors for these that are modifiable, we know these: hypertension, don't smoke, cholesterol, diabetes, the same that's for everybody. Obesity, having good physical activity, diet, and low stress. So a lot of modifiable risk factors for strokes. The types, again, there's thrombotic. This accounts for about 60% of strokes. The large ones are usually to do a thrombosis in the a larger artery, but you can have small arteries with little thrombosis, and these are called lacunar infarcts. You also can have embolic strokes. You can have an emboli, somebody be in atrial fibrillation, have an emboli in their atrium and throw it up to their brain and have a stroke that way. It can be caused from an emboli post myocardial infarction, valve replacement, some things like that can cause embolic strokes. Lacunar infarcts, just so if you read this on a CT or MRI, you'll know what they're talking about. This is named for the very small lacuna, or the cavity that's left behind when a little stroke has occurred. This occurs in small diameter vessels. And of course, the symptoms vary depending upon where in the brain this little stroke took place. But the prognosis is very favorable because it's only affected small areas. Transient ischemic attacks, of course, are when you have a transient episode of neurological dysfunction that is caused by a transient period of ischemia. Typically, we call these mini strokes, but they typically don't have any long-lasting symptoms. The symptoms usually last less than 24 hours. What we do know is that people who have TIAs often go on to have strokes, so it's really important to work them up. Some of their differential diagnosis for people presenting with some of these symptoms, is it a seizure and they're in a post-ictal state? Do they have a tumor? Do they have some encephalitis, some central nervous system bacterial viral pathogen causing these symptoms? Have they had a trauma? Subdural hematomas can be often missed in the elderly patients. They fall a lot. I said, about my head, I'm fine. 2 days later, they start having neurological issues, and it's a slowly developing subdural. And you can see these patients. You can have somebody come in and say, somebody you're seeing, like, he's not been asking right for the last 3 days. He's not himself. You start asking a few questions, you find out about a fall. So this is one thing to watch for, particularly in your elderly patients. You also was it a syncopal episode? Are they hypoglycemic? Are they intoxicated? Are their ammonia levels high? These are all possibilities. Transient global amnesia is an episode of anemia, of amnesia that comes out of nowhere, and it does go away, but it does present. You will think they're having a stroke. What you're going to see, You might see things like hemianopsis or loss of the vision on one side, loss of a visual field. You might see some double vision. Of course, we know about hemiparesis, hemiplegia. You might see ataxia. You might see dysarthria. You'll also see often some emotional things. They may become very labile emotionally, not be able to control themselves well. They can get depressed, withdrawn, hostile, angry, fearful. They may feel isolated. So there's a lot of things that happen emotionally post CVA, and often you're going to see these in your mental health setting. Sensory, of course, they can come in with paresthesia, such as numbness, pins, and needles. You often will see some verbal deficits. They may have expressive aphasia where they do understand you but are unable to express themselves. They can have receptive aphasia where they do not understand what you're saying. And they can have both. They can have difficulty swallowing. You can see loss of memory loss, decreases in their ability to maintain attention, concentration, poor judgment. There could be a lot of cognitive deficits associated with CVAs. When you have a left cerebral, of course, you're going to have right-sided issues. When you have a right, you're going to have left-sided issues. So just something to remember. I'm sure you know that. There's also some other things that you may see. One is the cerebellar CVA. These individuals will present with a sudden onset of vertigo. Really hard to, if you've seen somebody with severe vertigo, they have a lot of these symptoms. They have the nystagmus often. They have the vomiting. They have a gait disturbance because they're so dizzy. It can affect their mentation because their vertigo is so severe. But you can get a cerebellar CVA. So sometimes someone with severe vertigo does need to be worked up, and we won't get into that, but a cerebellar CVA can be missed. A brainstem CVA, of course, is severe, involves those vital responses such as our breathing, our heart rate, all of that, respiration. So somebody with a brainstem CVA has a very high mortality rate. It affects both sides. It's a bilateral thing, but they will have changes in level of consciousness. They may have nausea, vomiting, headache, vertigo, but they also will have issues with heart rate, respirations, and inability to control their temperature. A CVA is diagnosed. We always do, a pretty good workup with electrolytes, CBC, all those things. And always a non-contrast CT of the head is usually done because you don't want to do a contrast CT because what if this is a hemorrhagic stroke? You can make it worse. Sometimes they go straight and do an MRI now. We didn't used to have that capability, but now we do because what we know is that an ischemic stroke may not show up on the CT at first. Post-stroke management, you'll often see people with, they will be put on a dual platelet activating agents such as clopidogrel and aspirin. And remember that some of our psychotropic medicines, these are a few, I just put a couple here, but there's more. There's fluvoxamine and fluoxetine actually can inhibit clopidogrel. So they may need to be put on a lower dose of those. So something to be aware of that can be missed as well. They were put on a statin, encouraged to quit smoking. In the acute phase, they will often allow permissive hypertension in order to get adequate blood flow to the brain. But after that phase, we want to really control that blood pressure because that's often one of the causes. A hemorrhagic stroke, of course, is when there's a bleeding. It's a very poor prognosis. 50% of people will not survive in the first 2 days. Hypertension is the most common cause of these intracerebral hemorrhages. hemorrhages, hypertension, but they can be caused from some other things. You can have a vascular malformation. You can have some coagulation disorders, or B, I've seen these from someone's anticoagulants being out of whack. Trauma, cerebral aneurysms, drug and alcohol use. These are more common in males and more common in African Americans. Typically, these symptoms come on rapidly. They have a severe headache very quickly, followed by nausea and vomiting, and a rapid progression of their symptoms. So not a very good prognosis. But that is all. That was a lot for neuro. Promise the rest of these modules are not this long. All right. If you have any questions, please let me know.